Okay, so as you can see, there is the anatomy of neuromuscular junction. In anatomy of neuromuscular junction, there is presynaptic membrane and there is postsynaptic membrane. These are the receptors located on the postsynaptic membrane. So, and there are also some of the channels in presynaptic membrane. What happens? Calcium goes in and acetylcholine receptors and vesicles fuse with the presynaptic membrane and comes into synaptic space and bind with postsynaptic membrane. So on binding with the postsynaptic membrane, acetylcholine causes contraction of the postsynaptic membrane and muscle movement and contraction happen. This is the very basic and simple concept, but an autoimmune disease is there in which the postsynaptic membrane binding does not happen, and that disease is Mysthenia gravis. So we will be looking at Mysthenia gravis, that how it present and what finding it will have. It is an autoimmune disease. Mysthenia gravis is autoimmune disease caused by antibodies against postsynaptic membrane acetylcholine receptor, postsynaptic acetylcholine receptor antibodies, and this is type 2 hypersensitivity reaction, and it is asymmetrical muscle weakness present. Weakness is aggravated with movement, relieved with rest, and there is ptosis, diplopia, fatigue, and there will be some signs like a normal deep tendon reflex, papillary response is normal, no sensory abnormality, and no autonomic dysfunction will be there. So associated it is associated with thymic hyperplasia and thymoma, means it is associated with thymus, and Lambert-Eaton syndrome is associated with the lung cancer. Diagnosis is tensilon test. It in tensilon test, what happens? IV injection of adrophonium is given, and which is anticholinesterase, and it results into rapid movement of improvement of the symptoms within 30 seconds. So it is not routinely done. Another test that is accurate is electromyography, and antibodies like acetylcholine receptor antibodies should be given, and anti-musk antibodies are anti acetylcholine RA negative antibodies will be given. So it is very important to diagnose Mysthenia gravis and differentiate it with Lambert-Eaton syndrome. How can we treat? We can treat with acetylcholine esterase agent, and these agents waste therapy, and they prolong the duration of action of acetylcholine at neuromuscular junction, and most commonly used agent is pyridoxine. It increases the concentration of acetylcholine and causes contraction. And acute treatment is plasmapheresis, IV IgG should be given. Chronic treatment is prednisolone, immunosuppression, thymectomy. Our antibody positive patient, thymectomy is done. Extraocular muscle involvement treatment should be done accordingly for the treatment. There is another condition, that is Mysthenia crisis. It is exacerbation of the Mysthenia. Severe weakness is there. Respiratory failure can happen. Tensilon test is improvement. The symptom and treatment is immunosuppression, IV IgG, and plasma exchange is done. Another one is cholinergic crisis, occurs due to overdosage of anticholinesterase, fasciculation, paralysis, salivation, and constriction of pupil happens. Treatment is withdrawal of anticholinesterase drug. Endotracheal intubation is done if respiratory paralysis is there. So this is the Mysthenia gravis, and it is associated with the thymoma, and thymus resection is also the treatment of choice in Mysthenia gravis sometimes. So this is the thing that you have to keep in the mind and correlate it with the Lambert-Eaton syndrome. Both syndromes and conditions are different. You have to diagnose according to the findings and lab report.